guys are the beta testing group for the first run of ECG Jeopardy. I'm still working out the bugs of how to get it to go from one screen to the next. Almost you need to have two projectors, but who is this guy? Alex Trebek. He looks much grayer now, but how many of you have seen the Jeopardy game before? You remember that you may get clues, you may get some, in our case here, we're going to do some EKGs and some clues, and you have to answer the question, give the answer in the form of a question. This is
stuck. Yes. It gets stuck for first slide for some reason sometimes. So try again. Come on. Do you want to try one? There you go.
all right. We're going to have three groups. You can have members of your group that can be the spokesperson, or you can all yell it out at once. So this will be the Zumba group, this will be the Insanity group, and this will be the P90X or the T25 or whatever you like group.
Would you mind putting this on?
Okay. I honestly couldn't see, so if you want to move up and kind of keep continuity with the group, or switch groups if you don't like who you're with. All right, these are our categories today. Blocks, lights and drugs, rhythms, MIs, waves, and then go for it. And if we get through this one, I even have a supplementary slide group of give it your best shot. You know, it's one of the ones where at our national meetings and they call you up to the podium to describe an EKG, and the guy who has the slide says, you know, I told my secretary to take that one out, it's too hard. And you know, here you are, you're already weak-kneed, and you're trying to interpret an EKG in front of a group of 1,500 people. Okay. The Zumba group. All right, look at the EKG. And then I will give you a clue. So there's always an ECG, a clue, and then I want a question with which includes the answer. So that's the format for Jeopardy. All right. Anybody? I don't know, call an EP doctor. Oh, you don't have that. Well, we got the Zumba group here now. We're going to rotate back and forth. So now that's not the format now. What's the format for the answer? What is Mobitz 1, Mobitz 2, third degree AV blocker? I don't know.
What is Mobitz 2?
What is Mobitz 2? Exactly. Okay. Can you see it? You can't see it? Can you see it? All right. The Insanity group. All right. Anybody? Try in the back. Anybody can see it in the back? Here's Group B. All right, who's the spokesman? Dr. Ford, you can do this one. Come on. All right, what's the answer? I thought we'd zip through these, but I'm going to have to go back and do remedial cardiology now. All right, come on. What is longer drop? Longer drop. What is that?
The second degree type 1.
Mobitz 1, named after Carl Winkelbach. Okay? Okay? Gets a little harder now. The P90X group. This is, lest you be confused, this is the transition for each lead, so be careful about those. Sometimes you get fooled. This is not a QRS complex or a big giant T wave. So what is the rhythm? Escape rhythm, and they come in with syncope. You've got all 12 leads. What is
that third degree heart?
complete AV block? Okay. Nailing it. Okay. We're back to the Zumba group. Okay. A propensity of P waves here. Irene? This is, if you don't want me to call on people, I won't, but otherwise, I need some responses. Fixed PR when it does conduct, and then multiple Ps with no QRS. Absence of QRS complexes, but when it does conduct, it is not changing the PR interval. What is that? Mobitz 1, Mobitz 2, third degree AV block, ventriculophasic AV dissociation. What is it? Mobitz 2. Mobitz 2. Fixed PR. When you do, you don't see a PR prolongation. You may have multiple P waves. 4, 5, 6 come in the syncope. Mobitz 2. I fell down. Frequent need for why we put in a pacemaker. What's this part and what's this part? All right. The middle group. What is, it's got a little nomenclature for it. You know this rhythm. The most frequent rhythm we see in the hospital. What? Atrial fibrillation. And then this is called a snurd. Sinus node recovery time. The sinus node is having to wake up. And it's a long asystolic pause. So what is this called? It has a little name for it. Tachybrady. Tachybrady. Sinus node dysfunction or Tachybrady syndrome. Okay? Getting a little harder now. I know this is, if you want to come up, you can come up. I know these are a little hard to see. Sudden weakness and absence of pulse. Other than the ectopy or the irregular beats, so kind of a bigeminal pattern with APCs, the most common, the thing I wanted you to see is this. Now, what else could that be? It could be somebody gets choked. It could be middle of the night. I always look at your time when you're called to see a monitor strip or look at this strip, because middle of the night pauses is usually airway obstruction. The sleep apnea patient whose CPAP fell off. It can occur with a digital rectal examination, can occur with trying to put an NG tube down, can occur the first post-operative day after a surgery. It can occur after a heart cath. Sweaty, pale, ashen, and what is it? What's it called? What's the pause called? That's not Ashman's. Okay? We're the third group over here. What's shut off? What is there absence of here? Absence of P wave and QRS. So, sinus arrest. You had no escape rhythm. You had no escape rhythm. Okay. Look at all the leads. Something is too low. What gives you, all right, we're back to the, all right, I've got some people are speaking here. What is it? Potassium. Gives you U waves. What else? What is hypokalemia? Low potassium. Okay? All right. Sweat beads are popping out on the brows of Dr. Harris here. You know this one? Anybody know this one? Look carefully at it. There's a P in front of each QRS. But what's wrong about this ECG? Tall T's, so I'll tell you that the potassium is 4.5. What? Any? Well, you don't have J point elevation. I grant you that you can have, if you have an elevated J point and then you have these T's, it can be in the hyperacute phase for an infarct. What else can, look at your, I'd ask you to focus on intervals here. PR looks normal. The rate's 300, 150, 100, or 90 or so. What gives you this QT interval?
What is hypercalcemia?
What is, well, that's in the differential. All right. Let's say that I showed you this ECG and I said that this was a VF arrest survivor. It is a sodium channel problem, short QT syndrome. You know, we have long QT syndromes. We have 13 plus of them now. There are 3 short QT syndromes, and short QT syndromes are associated with VF arrest. It's usually a QT interval that's less than 280 to 300 milliseconds. Who has a longer QT interval? Men or women? Who is more vulnerable to torsade? Women. Women. About 470 milliseconds, 460 or 450 to 460 milliseconds for men. But this is short QT. You're right that if I gave you the lead in and I said this was a prostate cancer patient and his calcium was 16, that would be the answer also. So hypercalcemia can shorten your QT interval as well. Hypercalcemia. All right, remember you thought you got away from physiology. Here's an action potential again. We're which group? We're to the P90X group. All right, remember, now think about where in relation to an action potential, and this is a ventricular action potential, is your QRS complex and your QT interval. I didn't superimpose it on here for you, but I'm going to ask you a question. What phases of the action potential and ion channels most commonly cause long QT syndrome? Things that are iatrogenic that we create ourselves. It can be erythromycin, it can be many of our antiarrhythmic drugs, it can be hypokalemia, hypomagnesemia, all sorts of things. But what channels are most commonly affected that cause long QT syndrome? The inherited kind, not the iatrogenic kind. Phase 2 and phase 3 and the potassium channels. Okay? All right, we're back to Zumba group. This is a geometry class. Geometric sine wave and the pacemakers stop capturing. What is this rhythm? You lose your P wave. Your P wave goes away. You have sinus arrest. And the QRS complex becomes like this. What is it? What is? No. What's the mechanism? What gives you this rhythm? You're on the nephrology, sir. What is hyperkalemia? Okay. Potassium of 10. Okay. Look carefully. ST segments. This has a guy's name attached to it. Highly suspicious for proximal LAD stenosis. What is this called? You may have, if you rotated on with me, heard this term, but anytime you see the biphasic T's like this and deep T waves in which territory? The LAD territory. This is called Wellens syndrome. Wellens syndrome. Or Wellens sign. All right. I've been hurting for 3 hours. Different leads conveying specific location for an infarct. You know, we're used to doing the V1 to V6, the limb leads, the augmented leads, but in this one, I have given you a few extra leads to give you a clue. I have given you the anterior precordial leads, but I've also given you a V4R and a V8-9. Where'd you stick those? Posterior. All right. So you couple your information together here that I've given you, and look at the additional leads and tell me where this infarct is located. Inferior, anterior, posterior, lateral. Which leads? Which leads are elevated? Let's put it that way. 1, AVL. 2, probably starting up. But what else do you see? ST depression, V2 through V5 and all the way over to V6. But V8 and V9. Posterior infra-posterior infarct. Exactly. Okay. So RV infarcts for V4R and posterior infarcts that would give you a R greater than S in V1 and V2, and you would see if you have ST depressions anteriorly, you put the leads on the back. What does it look like? It's the mirror image. It's ST elevation. Posterior, when you put the leads on the back. Okay. What are these called? Do we need to call a cath lab? No, not epsilon wave. That's different. What is this wave? I'm not giving you we're all wizards here with the ECG, so what is this? What's that wave? It's a T wave. Is it small, medium, large, or giant? It is giant T wave. Giant T waves are neurologic T waves. You see it with catastrophic cerebrovascular problems, massive strokes, subarachnoid hemorrhages. Well, I started hurting yesterday, but I just finally got here. What is the infarct location? Name the territory. This is not, what is a blank infarct? What territory am I showing? Anterior all the way to V4 and a little bit of V5. So anterior. So what is an anterior infarct? The circles. Well, which group are we to now? We're just kind of back and forth. Are we insanity, P90X, or P90X? Okay. They get 2 turns. Give them a redemption turn. Okay, what's the arrows and the circles? Most common infarct location. What is inferior infarct? This is not wizardry here. You've got it. Q waves. Q waves. You see Q waves, it's a done event. What is in? So what else did we miss? Ah. Tall R wave, V2. Posterior. So in for a posterior infarct. Same thing here. What's the circle? What is that? It's a giant Q wave. Q waves in this location can cause bundle branch block, AV block. What's the territory? Septum. Septum. Anterior septum. Okay, we're back to the Zumba group. Or the middle. Hypotension, elevated neck veins, clear lung fields. What clue have I given you that nails it for this ECG in that presentation? Right-sided leads. Right-sided leads. RV infarct. Terrible to treat. You know, your pressors, you get heart block. Let's see. Okay. Mirror image consideration for infarct location. You don't have a big R wave yet, but here you have ST depression anteriorly. That would be ST elevation posteriorly. So where is this infarct? 2, 3, F, V4, V2 through V4. Inferior posterior. Okay. You may have, when you've been on the service with me, seen this. How do you tell an infarct in a paced patient or a left bundle patient? Called Garbosa criteria. It's just one of the screening things that you can sometimes see an infarct in the setting of a left bundle. So I wanted to show you the pictures here. So discordant ST elevation or concordant ST elevation in the inferior and lateral leads, or concordant ST depression in the anterior septal leads. So this is a means of seeing an infarct in the setting of RV pacing, which gives you left bundle, or just an intrinsic left bundle. Short of breath. Riding the saddle. That's all the clue I'm going to give you. What are your clues? Give me the... What is... S1, Q3, T3. And what's the commonest rhythm that you see with a PE? Sinus tap. Massive PE. Straddling the bifurcation. Salvador Dali's mustache. What is that wave? No. It's a drug that Dr. Alisani just ended up talking about. Digitalis vicosines, or digoxin. Gives you the scooped out ST segment. Okay? Doesn't have to be toxic either. You'll read it on EKGs all the time. Okay, we'll see if we get this one. Slurred QRS upstroke. WPW syndrome is the presence of a delta wave and tachycardias. You're absolutely right. And frequently this would be labeled as WPW EKG. But why do you get the slurred upstroke?
Early people.
It is pre-exciting the ventricle. You're getting to the ventricle over not only the AV node, but also over an accessory pathway. So you are pre-exciting part of the tissue there, and you get that slurred upstroke. And what else do you get? Short PR, usually less than 0.11 or 0.10 even. What is a delta wave? Cherchez le P. Where's the P wave? What is the rhythm? I tell you that the guy's eyes are rolling back and his blood pressure is 60/40. Where is the P wave? So when I say search for the P wave, I hope it's not la rather than look, but it's looking for the P wave. And P waves can be in unusual locations. They can be, you expect them to be out here, but they can be superimposed on the QRS complex, or they can be in the ST segment, and that's where this is. You see it right there. And you look for what's called Mirati's criteria. Mirati's criteria are pseudo S waves in 2, 3, and AVF. So there's your S wave, but that's actually an inverted P coming from ventricle to atrium, and pseudo R waves in V1. And if it's within 70 milliseconds or less, or you don't see a P wave at all and you've already converted it, or the EMS people have converted it with their adenosine before they get to you, it is usually a rhythm called AV node reentry. Commonish 60-70% of narrow, regular QRS tachycardias. So let's say I had this and it was, couldn't see a P wave, and it was a wide QRS with normal R wave progression across the precordium, and the rate was 150. What would you think of? Flutter, atrial flutter. So retrograde P waves can be, you can have short RP tachycardias and long RP tachycardias. What is this rhythm? Narrow QRS and AV dissociation. What is the rhythm? How fast is it? First off, how fast is a QRS? How many? You remember your Dubin criteria. If you either count from one interval to the next and count the milliseconds and divide into 60,000, or you do the old 300, 150, 175, 60, 50. What is this rhythm? Junctional rhythm with AV dissociation. So you may have poisoned the sinus node with 480 milligrams of metoprolol, and their junctional rhythm takes over. So what is a junctional rhythm? All right. Somebody gave this answer earlier. I'm going to give them an opportunity. What is beat 13? Beat 13 has a name. Why is it wide? What is the rhythm to begin with? What is long, short? What is this called? If I had a run of these and you got called for BT in the middle of the night, it would be the same thing, but it's usually preceded by a long, short interval, and then you get a right bundle. So Ashman's phenomenon. All right. This is different stages of the same condition. Different stages of an irritable condition. Okay, that was a good thought. I don't usually get that as an answer. Variant angina, which could, or Prinzmetal's angina with ST elevation, middle of the night, young woman, chest pain, ST elevation, and then it comes down. But then I've got something else here, though. You know, I had a cold 3 or 4 weeks ago, and I've just been hurting ever since. Pericarditis. What is pericarditis? So what is your pathognomonic features? PR depression, ST elevation, and then it gradually resolves and comes back to normal over about 3 or 4 weeks. What is pericarditis? All the conditions and the things that have people's names to them may get questions about it, but all right. This is a. I'll give you a clue. A Southeast Asian male who just ate some sticky rice, or somebody who just had a fever or got into a hot tub and fainted or passed out or had a VF arrest. What is this condition? What is Brugada syndrome? Okay, sodium channel problem, inherited, VF arrest. It's usually unmasked by flecainide or procainamide. You can unmask it with giving an antiarrhythmic drug, and it's called Brugada syndrome. Okay, you've seen delta waves. What is this wave? I'll give you the clue. Spike in the ST segments and a sudden death vulnerability in a 20-year-old male. Family history of sudden death. What is this? What is this spike in the ST segment? On an MRI scan, they have right ventricular myocardium and part of their septum replaced by fat. And they have left bundle branch block ventricular tachycardias. So what is this? You'll never, I think I've seen one in 17 years, but I took care of one guy and put in a defibrillator for him, and he had a VF arrest. But that's an epsilon wave. In the ST segment, usually you see it best in these leads, the precordial leads. Why? Because that's right over the ventricular septum. Well, you've seen this one already. Giant T waves, neurologic and massive strokes. All right. Your grade depends upon this one. I can't find the heart. Why can't they find the heart? They put the leads on the left side, and where's the heart? The right side. Okay? What would you see in lead 1 and AVF? What axis would you expect to see if you put the leads on of a dextrocardia patient in the normal left-sided heart location? Would you expect normal axis, left axis, or right axis? I didn't give you lead 1 and 2, 3, and F on here, but what would you expect? You'd expect right axis if you put them in the wrong location. So anytime you see declining QRS complexes and diminishing voltages across the precordium, they put the leads on the wrong side. All right, Final Jeopardy. A French bread roll. What is in unison? What is torsades? Okay? All right? Are you still game for a few more? All right, so this is, if you need something to study for and you like little tutorials, there's a nice tutorial that's not exorbitantly long. I mean, you can buy Chew, and which is 643 pages, or Mendel, that's 1,200 pages for ECG. This has good pictures, has good examples. So in your panic as you're preparing for boards, this is an excellent tutorial. Do I have time? I got.
Yeah.
Anybody who's after me? No me.
All of it. You have 5 more minutes.
Okay. All right, we're electricians. We deal with a lot of electricity. I had an attending who, in the process of cardioverting, defibrillating someone, the guy reached up and grabbed his arm right when he depressed the buttons. What happens to you if that happens? Why do we tell people to clear? My attending, Steve Hamill, flew across the room. He became part of the circuit. As opposed to the people who have an internal defibrillator go off and they're touching the person. Paramedics used to be fearful of doing CPR on patients who had ICDs because they thought they would be electrocuted. Okay, so we deal with a lot of electricity. We're all ECG wizards. You know, this is the usual. You know, this is a unique tramp stamp here, but this was a wizard. I thought it was great. And we don't want to be like this whenever we get to the board examination time, so we need to be studying our ECGs. All right? 3 seconds each. What is it? 1, 2, 8. So SVT or VT? SVT. Where's the P wave? The arrows in the ST segment. There's the P in the inferior leads, and there's the P in the ST segment. Is this WPW? Well, I've given you some of the criteria here that you're aware of. I had a guy drive himself to the hospital with a heart rate of 326. So is this WPW? And I want you to focus on V1 line that you may not be able to see very well here if you're in the back, but what negates this being WPW tachycardia? You are not one-to-one associated. You have to have an atrium and ventricle for every beat with a WPW tachycardia. Here you have it every other beat. What is this rhythm? Is what? What is this rhythm? Positive concordance, wide QRS. If their eyes are rolled back or not, you're thinking of trying to get them out of this rhythm quickly, but what is this rhythm? VT or SVT? VT. It is dissociated. It is, you'll never see a QRS complex look like this all the way out to V5. Okay, there are some arrows here. Tell me what this rhythm is. If Mama head comes in, I'll break it off. What's that? It's a P wave. So, and then here is a wide QRS tachycardia down here, but a narrow beat right in the middle of it. What features nail it for VT? Capture or fusion beats, and it's usually like the next to the last beat on a strip that they'll give you. At least they gave it for us like that. So the impulse got over the AV node to the ventricle and beat out the VT circuit. AV dissociation. There's a complete capture beat, and there is a fusion beat. So VT. All right, I'll give you a clue here. A man who likes to work out in the woods comes in with this ECG, after he pulled a few ticks off his body, what is this rhythm? What's the condition? Deer ticks related to what? Borrelia burgdorferi, okay? This will get better with antibiotics. They don't normally put a pacemaker in for this. All right, you saw this earlier. All right, look at lead 2 here. Look at the whole ECG, but I want you to look at lead 2 and tell me, why did it change from here to here? What? Can you see the bottom? Can you see the bottom? You go from something peculiar about these ECGs and then it goes away. The first 3 beats are pre-excited. And then the next beats are, this is a wimpy pathway. This pathway cannot conduct fast. You do not need to do anything about this pathway. This is pre-excitation. There's your delta wave, short PR. Delta waves can be positive or negative, so always, people have been cathed for delta waves because they called it a Q wave. But this is intermittent pre-excitation. Physiologic heart rate, it goes away. You leave this person alone. You don't have to do anything. VT or SVT? I just throw the hook out and just start reeling in here. Okay, VT or SVT? What is this beat? What's that beat? Even though it is spiky, it is VT. Why? Because you have fusion or capture beats. All right, the arrow, pathognomonic. It doesn't hurt as bad when I lean forward. Pericarditis, PR depression. PR depression. All right, this is a sneaky one. Sneaky, sneaky. Pay attention to the precordial, not the precordial leads, the limb leads for this one. Look at 1 and L. Well, this is peculiar because you've got upright P waves here in 2, 3, and F, meaning it's going from high to low. And you've got an inverted P wave here in lead 1 and an inverted P wave in lead AVL. What's wrong? They put the leads on wrong. They have right and left arm inversion. I'll end up with this one. Scratching an ear, tapping over the ECG pad. It's not the usual 2 east or 3 east or 2 south pseudoatrial flutter that we get consulted about, but this can be, what do you see going through? You see the QRS marching through. What is this? Artifact. Artifact. All right, we'll call that there. Dr. Mavahead's here. I'll get out of his way. I thank you. We'll do another test run of this. I'll get it so we can change from one bonus round to another round.